We are ready. Okay. So good morning, everybody. It is a great pleasure to be able to welcome you to this 49th annual Kenny Drash Memorial Lecture. This is a very special lecture. As you know, it honors two pioneers in pediatric endocrinology, Dr. Frederick Kenny and Dr. Alan Drash, who made incredible contributions not only to our institution, but to the US and the world. So a little bit about both Dr. Kenny and Dr. Drash. Dr. Kenny was the director of pediatric endocrinology of our division from 1962 to 75. He established the clinical endocrinology and basic research programs at CHP. He was the first one to use cortisol secretion studies to establish normal adrenal function ranges for children and adolescents. And he was considered by everybody as the Oslerian triple threat. He was described as a role model in terms of integrating clinical responsibilities, the mandate to teach at all levels, and continued inquiry into the mysteries of endocrinology. Everything I think we all aspire. Our other honoree is Dr. Alan Drash. Alan Drash was director of pediatric endocrinology and diabetes from 1975 to 1990. I had the privilege of meeting Dr. Drash. He was a member of my committee of my PhD thesis, and it was really a privilege to get to know him. Dr. Drash led the field confirming that insulin deficiency distinguished type 1 from type 2 diabetes. He was also a man of first. He was the first to use insulin immunoassay in pediatrics. He was the first one to use diazoxide in the treatment of hyperinsulinism. He was called around the world Mr. Pediatric Diabetes, and he was the president of all the three major societies in our field: the Pediatric Endocrine Society, the American Diabetes Association, and the International Society of Pediatric and Adolescent Diabetes. And when Dr. Drash passed away, his daughter Allison shared a letter with members of our division that stated this. This is a letter that Dr. Drash wrote to his daughter. And it said, "There is nothing more important than to be consumed by a sense of dedication and responsibility to a calling that takes one out of oneself and into the service of others. I could get by with doing far less than I do, but I love my work and the wonderful opportunities it has provided me. I'm excited every day when I get up and start to work because I know I will be presented with new chances to advance knowledge and help others." It still becomes a little bit emotional reading this because I think it really portrays how he felt. I'm also citing this because it also portrays how Dr. Schatz feels. Dr. Des Schatz, our honoree today, is a professor of pediatrics, and he's medical director of the Diabetes Institute, as well as director of the Clinical Research Center, CTSI, at the University of Florida in Gainesville. It's really an honor for me to have him here today. And I'm going to tell you a little bit about Dr. Schatz. So Dr. Schatz was born in Johannesburg, South Africa. He went to medical school here, and in 1983, he came to Gainesville, Florida. And of course, it looks like he has been having a lot of fun there because he never left. Not only he had fun, but he also raced through the ranks. He also did a wonderful job. He came to be professor of pediatrics, director of the Research Institute of the Diabetes Institute, as I mentioned before. And he also raised to be interim chief or chair of pediatrics at the University of Gainesville. All this, again, having a lot of fun. Not only that, but he has received numerous awards through his career. And I'm going to pull here a little bit my notes. It started in high school when he got school honors for academics, tennis, and cricket. And believe me, I tried to get a picture of him playing cricket, but I was not successful. However, I was able to get this picture from 1988 when he was a fellow and he got the Kokomura Award, honoring an outstanding resident or fellow in the Department of Pediatrics. And you can see, even here, he had his ever-present smile. Since then, he has received numerous awards. I'm going to just cite a few. The American Diabetes Association Bunting for Leadership and Service Award in 2016, the ISPAD Prize for Achievement in 2016, Lifetime Achievement Award from the University of Florida in 2020, the JDRF George Eisenbarth Award for Type 1 Diabetes Prevention in 2021, and he became a member of the Academy of Science, Engineering, and Medicine in Florida in 2022. This, among others. He also has an incredible record of publications. I will tell you that I stopped counting when I got to 400. Not only that, he has also presented in many, many meetings. His pages of presentation in his CV are well above 10. So again, I stopped counting. In 2016, he was chosen to be the president of the American Diabetes Association. At his presidential address, he underscored the need to bring diabetes to 212 degrees, and I still remember this presentation. It was very impactful. 2012 degrees, the boiling point of water with it erupts with urgency to transform the invisible disease to a highly visible crisis, calling for more research, advocacy, and education. As important, if not more important, Dr. Schatz cares enormously for families he takes care and for his team members, for the group of people that work with him. This is a picture of some of his research team and also him working with the TrialNet family. And TrialNet, a study that looks at interventions to prevent type 1 diabetes, has been the avenue where we have gotten to know each other. It has really been an immense privilege, and this smile that you see here is the smile that he always has. He's incredibly generous. He's a great mentor, even at a distance, and we are tremendously happy that he's here today to be our 49th annual Kenny Drash Memorial Lecture honoree, where he's going to present on beginning of the end of type 1 diabetes, progress towards the prevention and cure. Dr. Schatz? Yes, thank you. You're okay? I'm going to just close this out. Yes. Here. And there you go. Okay, thank you. Wow. Well, firstly, thank you all for coming here this morning. It's been so crazy for all of us during COVID and what used to be packed rooms. Now we have the opportunity to both be present in person as well as do this on hybrid. But I really do also want to take this opportunity to thank Ingrid. Ingrid, I wish my mother was here to have just, heard a little bit about what you said. I always wanted to be a professional cricketer, but instead as I was saying, the only thing I learned was to spell diabetes. But anyway, having said that, thank you very much for a wonderful introduction. And I want to thank Dorothy Becker, Radhika, Terry, for the wonderful invitation that's been extended to me to come to Pittsburgh. And so far, my visit has been absolutely spectacular. And I do have wonderful memories of Alan Drash. Alan Drash was a mentor. Alan Drash was a very kind person who, I remember at the time I was a fellow because I was deciding to come to be a fellow either here in Pittsburgh, in Denver, or in Gainesville. I ended up staying in Gainesville. But he didn't put any pressure, and he just, put out all the opportunities that existed at this program. And that was something, because very often we pressurize people or we try and sell programs, but he let the program, which is internationally recognized in the field of type 1 and type 2 diabetes, stand on its own legs. And for that, I was really very impressed. But I'm going to talk today a little bit about the beginning of the end of type 1 diabetes, and some challenges and opportunities to interdict and to reverse type 1 diabetes in 2024. If anybody has any questions or during the talk, just stop me. That's the way it can be. Otherwise, there'll be time, afterwards for questions. So my disclosures, I have been very fortunate, very lucky to be supported since the early 80s with NIH grants, and I currently still have support through the Human Islet Research Network, through TrialNet, although I ceded PI responsibility to Mike Haller, through Teddy, through the National Institute of Allergy and Immunology Disease. We with Todd Brusker as a program project grant. We still do a couple of ITN studies, and then I'm fortunate to be one of the co-PIs of the
NPOD studies, which is pancreatic donors. And I'm going to talk about that tomorrow, and some lessons we're learning tomorrow that may change the textbooks and what we think about how type 1 diabetes develops. And then I've worked as a consultant for Korea, Pupil Bio, and Biomea, but that has nothing at all to do with this talk. So how did I get this title? You know, Charles Talleyrand Perry Gordon, I apologize for my poor French, in 1812 said it is the beginning of the end. And, you know, how did he get to this? Well, you know, the Battle of Borodino was a bloody Napoleonic war, and it was fought in September the 8th on the river Moskova, which is near Moscow. And it was towards the end of Napoleon's invasion of Russia, in which he actually had a fairly decisive victory over the Russians. However, it involved more than 250,000 troops, over 1,000 guns being destroyed on both sides. And although he won this decisive victory, he really lost the battle. Now, that was when he said that was the beginning of the end. But Churchill, on the other hand, said, no, it is not the beginning of the end. It is perhaps the end of the beginning. And after a series of defeats in the Second World War, Churchill could finally tell the House of Commons in 1942 that he had a new experience, that in fact, it was the end of the beginning. Because what had happened was that Alexander and Montgomery had turned back Rommel's forces after having suffered significant defeats at Dunkirk and also in Singapore. And then he said, which is something that is not part of this, but he said that I've not promised anything but blood, sweat, toil, and tears. And when I think about diabetes and I think about how we're going in terms of our quest for prevention, I do know that it's going to still take a lot of blood and sweat and a lot of toil. So what are my goals for this morning? To quantify the burden of type 1 diabetes, to enhance the knowledge of the natural history of pre-type 1 diabetes, which gives us an opportunity to think about prevention and cure, to identify some of the reasons why type 1 diabetes has not been prevented or cured to date, and to evaluate some current, effective, and future approaches towards preserving and restoring beta cell function. Okay, the need to prevent and reverse the burden, type 1 diabetes in the United States is still rising. We have a prevalence of 1 in 300, or approximately just over 2 million Americans with type 1. The annual incidence is over 20,000, and the most rapid increase is in kids less than the age of 5. And I'm sure all the educators are saying, what's going on here? We're getting a lot. This last year, we've been getting 1 or 2 a week, and I'm sure in Pittsburgh, with a greater population, you're seeing much more than that. So it is a rising, and the prevalence is expected to reach 5 million by 2050. There's still morbidity and mortality, despite the incredible work that Trevor Orchard, who I had the opportunity of seeing last night, has done, where he showed that really through his long Pittsburgh study that really he began, I don't know how many years ago, that patients who do not develop overweight and obesity and with good control lead a normal lifespan. Incredibly powerful work that comes here from Pittsburgh. There are still acute complications of DKA and hypoglycemia, micro and macrovascular complications, and I'm still going to show you an inability to achieve glycemic control up until perhaps most recently. Very staggering economic burden, over 20,000 per year for type 1 diabetes. The hospital charges for a DKA admission, incredible, is over $30,000, and even more if you stay more than one night. And the annual medical costs and lost income per the ADA for this year is over $14 billion. So staggering toll related to diabetes. Now, during my presidential address, about 7 or 8 years ago, I talked about some of the major successes in the past 25 years. And that was the demonstration through the diabetes control and complications trial that tight control reduces complications. When I first started with Arlen Rosenblum, some of you may know, passed away recently, we didn't really know that. You just simply said, take insulin and, you know, that'll be fine. But we know that tight control makes such a difference. And because of that, it has led to incredible opportunities for intensive management. Technological advances, and now we're at the hybrid closed loop system. We've had a better understanding of beta cell biology leading to replacement of beta cell function, and, you know, Starzl and so many others in Pittsburgh have done so many transplants and led the way with both whole pancreas and islet transplants. And we have found that type 1 diabetes is a readily predictable immune-mediated disease. What this does is it sets a stage. It sets a stage for the cure. It sets a stage for prevention. But in a way, let's look at these things, because what we were talking about yesterday is let's rather under-promise and over-deliver. We have not over-delivered as of yet. So insulin is a great drug, but it is not a cure. We're unable to reverse the disease with either islets, whole pancreas, or stem cells for more than a short period of time, and we still don't have a durable prevention, although I'm going to show you some data that gives us some hope. So there have been clear improvements in diabetes care. We start off in 1922 with Banting and Best, the discovery really of the Hagedorn, the NPH insulin in the 40s and 50s, you know, the early pumps, Bill Tamberlane and others in the 1970s. And then we got meters that were rapid. And then we got onto continuous glucose meters. And now we're getting onto pumps, and we're attempting to close the loop. So there have been clear improvements in care. However, and this is actually a very telling slide that I got from the Type 1 Diabetes Exchange, because we asked that despite these improvements in technology over the last how many years, are we reaching targets? And these are data from 2018, and looked at 2 cohorts enrolled in the Type 1 Diabetes Exchange, about 25,000 people, and was very disappointing to me to see that less than 20% of patients, either in the initial cohort or in the subsequent cohort, reached a hemoglobin A1C target per the American Diabetes Association target of 7%. And remember that that has changed over the years, but so few people were reaching target, and this is in 2018. And we know, we take care of patients in the clinic, that there's still a struggle with glycemic control. I mean, these again are data across the ages and looks at trends in A1C across the lifespan. But this time it looks at 2016 and 17 through 2021 through 2022. Now, what you can see, if you can see in the orange line, that's 16, 17, and the blue line is 2021, that you do see that there is a slight improvement in glucose control, as reflected by both time in range, which I'm not going to show you, as well as by hemoglobin A1C. So things are getting a little bit better. And you may ask, well, why are things getting a little bit better? Well, because we've had this evolution of diabetes technology really over the last decade. And I just want to briefly go through why we're seeing this. We've gone from open to closed loop adaptation. In the initial patient-controlled open loop, we had insulin injections. I mean, we were all brought up with insulin injections and insulin pumps. And then we got a continuous glucose monitor, which I will argue is really the reason for the incredible improvement that we're seeing overall. We went to partially automated insulin delivery with low glucose suspend and predictive low glucose suspend. And now, excuse me, we have a hybrid, what we call hybrid closed loop, with basal rate adjustments, basal meal and high blood glucose adjustments. And what has this led to? This has led to increased time within range, a reduced frequency of hypoglycemia, which is the thorn in every parent of a young child's mind. They can't sleep, we can't sleep. It's a concern. We've had improved overnight control. And the whole goal of all this is to ease the burden of disease, improve short and long-term outcome till we get to, if we ever get to, an artificial pancreas. And I will just argue, as I just said to you, that the greatest technological advance, really, because whether you're using pumps or whether you're using insulin injections, has been the use of a CGM, because one can clearly see that the hemoglobin A1C, which is shown on the y-axis, and this is age over the x-axis, the hemoglobin A1C in those that use CGM, at least for part of the time, is significantly better than those who don't use continuous glucose monitor. So again, I would throw out the challenge to you and say that has diabetes control with type 1 diabetes improved? And I would probably say to you, prior to 2018, probably not. Yeah, we had a lot of technology, but had we really done anything? But now in 2024, we do hope to have turned the corner. But, and I could spend the next 2 hours going through this, but I'm going to just throw out some things because I want you just to think about some of these things. Why have type 1 diabetes not been prevented? And I remember during my American Diabetes Association address, during another talk, somebody had said to me, well, you know, why haven't you cured diabetes? You've done pretty good in cancer and you've done well with some of the other chronic diseases, but not in things. And it says, are you not working hard enough? And I said, no, I think we're working hard enough. We're probably at this stage not smart enough to understand that. And I think some of these are put down here. And if anybody wants to write a chapter, you know, here are some of the things you could do. Animal models are not necessarily indicative of human disease. We don't know the mechanisms leading to type 1 diabetes. You know, we assume, oh, and I'm going to show you another slide. We assume, oh, it's T-cell mediated destruction of the beta cells of the pancreas. Well, if it was that simple, many of these immunotherapies should have worked by now. And we've also failed to embrace the disorder's complexity. We've also have an inadequate acceptance of the disease heterogeneity. You take care of kids in the clinic. No two kids are the same. It depends. You know, there are a lot of behavioral. I always say type 1 diabetes, yes, is a disease of lacking of insulin, but it's also a behavioral disease. You don't have the right family, you don't have the right teacher, you don't have the right support, you don't have the right finances. The outcomes are very different. It's a different disease. Lack of informative biomarkers. You know, I get on Laura is one of our colleagues, and I say, Laura, you know, spending enough time on this. When are you going to give us some informative biomarkers? Being part of TrialNet, we just have too few rational plans for agent selections and too few combinations. We only treat an immune response. We have study design issues that I believe we should it's okay, you know, if you're a pure statistician, you don't want to make a type 1 error, or my feeling is make a type 2 error. You could get a smaller study design. There's limited pharma interest, to be frank, unlike type 2 diabetes because of money. There's a lack of understanding of pancreatic pathology, and that's what I'm going to talk about tomorrow. You know, how pancreatic donors have really helped us change our understanding about diabetes. And there is a dogma and an inability to move, you know, beyond it. So this is the speculation on mechanisms. It's a busy slide. It's a complicated slide because we don't know what's going on. I always say, you know what's going on? You put in 2 little slides, and this is it. This is to show how complicated this is, right? This is to sort of show, okay, you have here the beta cell, and here you have the whole, you know, the immunological armamentarium. But in essence, what it is that in a state of tolerance, you have more regulation and less killing. In a state of autoimmunity, you have less regulation and frankly, more killing. And that is about what we do know. And the important thing, and I want to bring this up again, is type 1 diabetes a classical autoimmune disease? You know, we've been looking for these so-called triggers of type 1. You know, we know celiac disease, you take gluten or whatever it is, and you're going to have an autoimmune response. But we don't treat celiac disease with teplizumab and with anti-thymocyte globulin. You don't want a gluten-free diet. We've looked for all these things. We haven't found it. We haven't found it. We don't treat autoimmune thyroid disease with heavy immunoregulatory, immunomodulatory, immunosuppressive agents easy. We replace it with thyroid, or we give, you know, something else like that. But we don't know what type 1 diabetes is. And is it a suicide? Is it a homicide of the beta cell? Is it a bystander? Is it a perpetrator? And I think these are absolutely critical questions, and it's something that our group is really focused on. And even now, one of the major questions is, does the peripheral blood itself reflect what's happening within the islet cells and the draining lymph nodes themselves? So it's a complicated slide, but what it also does is it gives you an opportunity to intervene at any part of that immune system. And that really has been done. Then there's the challenge of relapse and remission. And if type 1 is a classical autoimmune disease and we design whatever studies we are, where do we know where we are? You know, it's not like, unfortunately, if I show the arrow over there, you know, you've got beta cell mass, you've got genetic predisposition, and then you get the disease. It's not like you get off the top of the slide like a kid in a park that's on the top of the slide and you slide down. You know, it's quite quick. You get top, bottom, you pick the child up, they go up again, they come down. No, not in type 1 diabetes. There are some people, particularly in younger people, who do that. But there are also some people who go slower, and then there's relapse, then there's remission, and frankly, they don't progress. There are some people in which that happens, but we're not able to yet tell. And as a result, all our studies have been cloudy at very best. So what is the road to preventing and curing diabetes? Well, the way I like to look at this is we've got to think about prevention as the most important thing, because if the type 1 diabetes is an immune-mediated disease, it has memory, right? The immune system has memory. So even if we are to go in and replace, the disease is going to come back because we probably have not gotten rid of the provoking autoantigen. So we've got to think, when we think cure, we've got to think prevention. But what do we think that we've got to do is, and this is where I think that our field has not thought enough outside the box, that yes, it would be great if we could prevent the onset of autoimmunity. Wouldn't it be great if we had a vaccine? That would be really wonderful. But we've got to stop the autoimmune attack, and we've got to preserve and replace beta cells. Because think about it, type 1 diabetes is a disease of beta cells. It is a disease of the beta cells. And I think when people forget that, it's not the alpha cell, it's not the delta cell, it's not the pancreatic polypeptide cell, it is the beta cell. So we've got to think about ways of restoring that health. And a lot of research that I'm actually doing with Yuval Dor, a wonderful scientist in Israel, is to try and understand what's going wrong within the beta cell that either serves as a trigger or in itself causes its own demise. But I think that is going to be really a great challenge, is to find out what's going on with the beta cell. Well, over the past few years, and I was fortunate to be part of a group headed by Dick Insel at the JDRF, a busy slide, but really we can now think about type 1 diabetes as having various stages. You know, certainly in type 2 diabetes, you know, and so many, and, you know, I also want to give credit to Silva Arcelanian, who really has led the field together with Ingrid, you know, in type 2 diabetes in youth and adolescence. There's certainly a pre-diabetes, and now we have if you will, if you think about just conceptually, you have pre-type 1 diabetes, which then gives you, if you have genes you have the opportunity of a primary prevention, and that's there. We have stage 1 diabetes, which is evidence of beta cell autoimmunity by having 2 or more antibodies, but normoglycemia, that's called stage 1. Stage 2 is 2 or more antibodies, but this time you have dysglycemia and what we call pre-symptomatic diabetes. And then stage 3, which is symptomatic diabetes and the progression to clinical disease. Well, if you know that there are different stages, this gives you an opportunity to interdict the disease, to change the course of the disease at different stages of type 1 diabetes. So I could tell you about, there have been over 120 studies in the last 10 to 12 years in type 1 diabetes. Here are some of the more successful studies in stage 3, which is new onset. And these are data from Laura Jacobson's and looked at 2 years post-diagnosis and really compared the most successful. These are some of the most successful studies. These do not include the more recent studies, but the studies that were published in 2020. And there were 2 studies that stood out. And they looked at C-peptide, which for the non-diabetics is the endogenous insulin. You can't measure insulin when you're giving insulin, so you measure it by C-peptide. Excuse me. And the 2 studies that were most beneficial were anti-thymocyte globulin and tepalizumab. That's an anti-CD3 monoclonal antibody. And compared to placebo, there was 103% improvement in C-peptide for ATG and a 63% improvement for tepalizumab, which said that those 2 compounds, those 2 therapies had the most promise for adaptability in the future. Here are some data from Mike Haller and the group, and also the Pittsburgh group is very active in the trial net, and Dorothy and Ingrid were enrolled a lot of patients within this. And if you simply look at the natural history of C-peptide, which is shown here in the red for placebo, what you can really do is compare to the blue with the ATG, and there was a significant improvement. In other words, in C-peptide compared to placebo. You'll also see another line there, which was a combination of anti-thymocyte globulin and GCSF, granular colony stimulating factor versus placebo. That too was effective, but clearly you could see there was a greater effect seen without the GCSF. But one of the things that I want you to know is that the effect is not durable. And what you see is if you're going to see a change, you see it in the first 3 to 6 months, because you can see what's actually happening here is that the placebo group after 3 to 6 months falls, and that the preservation occurs in 3 to 6 months. That's a very important thing, and why our institutions, why our trial net groups haven't said just do studies for 3 to 6 months because you'll be able to sort out responders versus non-responders has baffled me for several years. But I do believe that that's it. People want to see durable effect because it's an immunotherapeutic agent, and we can debate that afterwards. But what you can see is that this effect was fairly durable, certainly for 2 years. And if we look at this, it also had a biological effect as well, because if you looked at hemoglobin A1C in the very closely treated group, the hemoglobin A1C was better in those treated with anti-thymocyte globulin compared to placebo. But there are other studies that have also shown in the last couple of years some effect. And one is a TNF alpha blocker. This was done as the Tiger study. And what you can see, there was a group that was treated, and there was a group that was not treated, and you could clearly see again the separation that occurred. This is in weeks, so it's a little bit confusing. But what you can see is that they stopped therapy after a year, and then there was really no difference at 2 years. So if you are going to use a therapy, you need to not stop it if you do show effect. And they showed effect initially, but and that's why I said for financial reasons, J&J decided not to proceed with golimumab, this TNF-alpha study. More recently, published in the New England Journal, was another study, the BANDIT study in recent onset diabetes. And this came out of Australia, baricitinib, a JAK kinase inhibitor. And what they were able to do was to show that there was an improvement in C-peptide, as well as in hemoglobin A1C, as well as a reduction in hemoglobin, as well as a reduction in insulin dose. So not only did it affect beta cell function, but it also had an effect on patient outcome, which has not been the case really for all the studies. And this was another study that was recently published in JAMA. Greg Folenza, who was another of my students, who's now at the Barbara Davis, and they showed that verapamil preserved C-peptide, very interestingly, but really did not have any impact on glycemia. Now, that's a very important question, and the answer is why, and you start getting back to things about DCCT and edict, that maybe there's memory and does it really matter, and we'll have to see the long-term outcome. The sad part of that particular study is that verapamil was stopped at the end of 1 year, so we'll really never know. And also then there are other approaches that are being used besides these immunotherapeutic agents in new onset patients, and these are to try and induce tolerance with plasmids, to use different beta cell peptides, and then to do cellular therapies. So right now in new onsets, there are multiple approaches, and the jury is out as to whether any of them are really going to be effective and durable. So that's really, if you will, stage 3. But what about stage 2? What about trying to prevent or delay the onset of diabetes? And remember, what this is patients who have 2 or more antibodies, dysglycemia, and they're pre-symptomatic. And how do we get there? And these are data initially from Annetta Ziegler, in which she combined several studies. And on the y-axis is the probability of progression to diabetes, and on the x-axis is the follow-up from seroconversion. But the bottom line is that if you've got 2 or more antibodies, you've got a 44% risk at 5 years. In 10 years, you've got a 70% risk, and at 15 years, you've got an 84% risk. So by knowing that risk, you can sit down and speak to the families, these are relatives, and explain that risk very carefully, and what are the benefits of doing something versus the benefits of not doing something. And we've certainly learned that. And we also do know from the diabetes prevention trial and also within TrialNet that if you actually have these antibodies and in fact you have glucose intolerance, then the risk of developing diabetes in 5 years is 75 to 80%. So the more and more we understand about the disease, and then also with more other things like genetic risk score, GRS, genetic risk score, and glycemic index, and things like that, we're able to get better biomarkers to predict the actual rate of the disease. So that gave rise to a study, the tepalizumab stage 2 prevention study, in which this anti-CD3 study was given, this drug was given over 14 days to patients with stage 2 diabetes. It was done across the country. Pittsburgh was very involved, as the University of Florida. There was initially 108 eligible subjects, 76 eventually completed the study. And what it showed, and I want to perhaps just raise a question for all of you, is you can see that there was certainly a delay in the onset of diabetes in the tepalizumab study. And that's in red, and this is compared to the blue. And what you can see here is that in essence, at the end of really at the end of 2 years, which is over here, there was about 50 to 60% of the placebo group and about 30 to 40% of the teplizumab group that had gotten diabetes. Now, what you can see, it's not a straight line, but at the end of the study, there were really a couple of conclusions, and I want to say what the conclusions were. That it was the first one that met its clinical endpoint in delaying the onset of type 1 diabetes, and at the end of the trial, 25 out of 44 were diabetes-free. Now, if you turn that around, that meant that 43% of the people were not diabetes-free. So yes, there were some responders, but not everybody responded. So you may say that given the burden of diabetes, any time without clinical diabetes may be significant. Now, I have a problem with that in a sense that you've got a 14-day course of therapy. The disease is heterogeneous, acts differently in different people. The cost is $250,000. You have to bring the patients in for a 14-day infusion. And the question is it, if we did it, could we predict individual benefit? And is it cost effective, particularly now that we have, hybrid closed loop systems and, I don't want to raise unnecessary expectations. So it's just something to think about. If it was free, it was in the water, and we could do that, and we had good biomarkers, there would not be any challenges at all. And so you ask, well, why hasn't the anti-thymocyte globulin study, which is cheap, the cost is about $5,000 or $6,000, has that been used? And there are some challenges. It also is owned by Sanofi, who owns teplizumab, and if one thing costs $5,000 and the other's $250,000, you know where the investment's going to be made. This is only a single course, and the goal within TrialNet is to randomize 114 subjects. Right now, the enrollment has been very slow, and it's not a surprise because one is FDA approved. And I hope that this study will get done because I think it's a very important study. So I do want to also mention that this year, the American Diabetes, have said that screening for pre-symptomatic type 1 diabetes can be done by the detection of autoantibodies to insulin glutamic acid decarboxylase IA2 or zinc transporter 8. That has always been part of the guidelines really for a couple of years, but this time they took it out. They took out the words in relatives. Now you may recall that 90% of type 1 occurs in the general population, but 10% occurs in relatives. But in relatives, the risk is 1 in 20, but in the general population is 1 in 300. So the reason for this, there's been a lot of push by the pharmaceutical industry to get the general population screened. Again, I have quite a few reservations about it, but there is good reason to do this. And that's, you can make an earlier diagnosis, you may be able to prevent DKA, better understanding of the natural history of prediabetes, and to gain insight into etiology and immunopathogenesis. And we need to identify individuals for prevention trials. So I think that this is what you're going to be hearing a lot of, but I also want to say is you need to sort of think about what is it in the year 2024, what is the cost of doing it, what is the emotional toll of knowing risk, and as genetics, determination of disease becomes a lot more reliable and predictable, we'll be knowing a lot about risk of diabetes and many other diseases in the not too distant future. So how do I believe what we're going to be doing for prevention? We're going to need to really think about 3 components of the immune system if we are going to be successful. That's innate immunity, adaptive immunity, and regulatory immunity, which we don't think about all of those together, as well as to improve beta cell health. And here's just an example of something which, you could say is, use a combination of an anti-inflammatory agent such as anti-TNF, which I spoke about, an immunomodulatory agent, which is anti-thymocyte globulin or anti-CD3. You could infuse and drive Tregs with IL-2, antigen-specific therapy, and one of our fellows just got one of these grants to do an mRNA conjugated, sorry for the spelling, islet antigen, and then to restore beta cell health with stem cells or gene therapy. There's some exciting stuff that's happening, or to use, drugs that are being repurposed, such as GLP-1 and verapamil. Okay, I'm going to take the last, let's say, 10 minutes just to give a quick overview of where I think that we're going in terms of cure. We do know that we can replace beta cell function, and really Pittsburgh has been really a leader in pancreas transplantation for many years. It's usually done in accompanying kidney transplantation, the so-called sequential pancreas kidney transplant, the SPK, and then islet cell transplantation, which has been usually reserved for recurrent severe hypoglycemia, which is an interesting indication in itself, because I also believe that recurrent severe hypoglycemia is a very soft diagnosis. I really think a good doctor working with a good family and a good patient can often, get rid of this so-called unexplained hypoglycemia. But that's a cause for another discussion. But we do know about, if you compare pancreas and islet transplantation, yes, there are some issues really with both, but it certainly works for a little while, but certainly is not the cure. And the reason is that there are too few donors. HLA matching does play a role. I do have a slide, which I'm not going to show you here, that if you are able to HLA match, particularly with islets, you get a better long-term outcome. But again, what are you swapping? You're swapping a disease for lifelong whole body anti-rejection drugs. We don't have the availability and source of cells that we would like to have. And, hopefully people like Holger Russ, who we recruited, who's trying to do a couple of things, who's hoping to both differentiate stem cells into islet cells, and another of his projects, which, always looking for good graduate students and postdocs, is trying to create a thymus from stem cells in a 3D fashion. And then you have obviously rejection, alloimmune responses, and then the hardest of all is you haven't gotten rid of the initial autoantigen, so you get recurrent autoimmune responses. So what are the stem cell strategies that people are really working on? You've got patient-specific with reprogramming and transdifferentiation. Then you've got allogeneic adult stem cells, and then you've got human embryonic stem cells or induced pluripotent stem cells. And the advantage of the latter particularly is they can be used for multiple patients, and they can be centrally produced and more easily commercialized. But this was a beautiful slide that I gotten from Desai and Tang from Nature Reviews, in which they talked about the hurdles of beta cell replacement. And the first one is really the limited source of beta cells. So we've got to create an unlimited source. And we can get that from stem cells, and maybe now even xenogeneic from islets from pig or from others. We've tried in the past, but there were issues with zoonoses, but maybe we're overcoming that particular barrier. And then we've got to say, well, what about the next? You've got enough. What about the survival of transplanted cells? Well, how are we going to do that? Well, we've got to protect them from ischemia. We've got to protect them from inflammation, from the immune response, and we've got to get accelerated vascularization. Well, what about the need for lifelong immunosuppression? Well, either you've got to encapsulate or you've got to fool the immune system, and I'll show you one or two sort of way out gene editing approaches, to doing that. And then you've got problems down the road with capsule fibrosis, which is a big problem with these islets, and bioincompatibility. And once we can overcome all of those, we can get to insulin independence. But I think we have to realize that these are challenges that we're going to need to confront in the next few years. So again, I do think that, this is what's happening. There are already, and you're probably aware of this, ViaCyte have really created and have got over 500 employees trying to get enough islets, insulin-producing cells, to eventually replace. Some of their work has been stopped, is put on clinical hold because of 2 deaths of the patients. So there are clearly some issues that they're working around, but at least it gives cause, or at least hope, that they'll be able to derive stem cells that make insulin-producing cells in a much bigger fashion, and will be able to optimize tissue delivery. So how are we going to do that? And how are we going to do that? Well, obviously, you've got a physical barrier. You can think about macroencapsulation. You can think about the immunomodulatory agents, which we've got to be thinking about at the same time, which we've already talked about, or which was just fascinating to me, was gene editing of stem cells for immune evasion or immune protection. And just here are just a couple of way out slides, which make a lot of sense. It sounds so easy, but these are just, the geneticists will know much more. Dr. Nichols really is an authority here. I had the pleasure of working with him when he was in Gainesville. But, you know, if HLA is so important, and we know HLA is very important, it's definitely necessary, but I know it's certainly not sufficient to lead to type 1 diabetes. But if theoretically we could get rid of class 1, HLA class 1, which is on chromosome 6, and HLA class 2, gee whiz, we could in fact get rid of the immune system somewhat. The problem with that is that if you got rid of it, natural killer cells would come in and knock out really all the cells. So what you can then do is, not only do you have to gene edit, you know, with CRISPR-Cas9, not only do you have to gene edit, but then you have to insert other HLA, such as HLA-G, which is then capable of modifying a natural killer and T cell activity if you were to put a PD-L1 gene in at the same time. I think these are things that are being done in a dish, but are clearly not ready for prime time. And then there are other approaches, such as, you know, to perhaps bypass the pancreas and to deliver insulin and a glucokinase gene therapy, certainly to muscles. So there are a lot of works, you know, in progress, and I think at least it gives us the opportunity to think that really we're getting close, you know, to at least thinking of the beginning of the end. I think much progress has been made, again, in prediction. Much progress has been made in prevention. We're thinking now about islet replacement, and a number of challenges do remain, but there is hope, because that's what drives us. There is hope, realistic hope, for a biological cure. And with that, I really want to thank most of all the patients, and then all the funding sources that we have had to enable us to do the studies. And then this is a picture taken during COVID, which says it all, but you know what? We were all out there with masks, but everybody was out there. And one of the things that our group has been able to do from a research perspective in the lab is to come into work every day. And I think that that has been a really big help in terms of trying to build team camaraderie, to ask important questions, to be around each other, to give, to boost morale at particularly times, you know, like this. And, you know, I always say, you know, being in a close locale and being able to even bump into somebody for us as men in the toilet and ask a question, you know, standing next to, you know, and you're asking the guy and say, hey, by the way, did you do that experiment, you know, that we talked about in the lab meeting? And, oh, yeah, here are the data. It sort of stimulates you on to more things. But anyway, I just want to thank you guys for your attention. Again, want to thank Dorothy, Radhika, Ingrid, for giving me this, what I think is an incredible opportunity to speak at, you know, the Drash Kenny Symposium. And I really look forward to my other talk with the adult endo group and to interacting with the fellows, because, you know, you are the future. We haven't cured diabetes yet. And so it is our hope that you, the next generation, will do that and can say, hey, remember when this happened, but now we've cured diabetes. So thank you very much.